All attendees are in listen-only mode.
Hi everybody and welcome to the National Hispanic and Latino ATTC's webinar, Opioid Use Disorders Among Hispanics and Latinos. Today's webinar will be presented by Dr. Hanner Hernandez, and I will tell you more about him soon. During today's webinar, all participants will be muted. The audio will be streamed through the computer, so please make sure your computer speakers are turned on and up to hear today's presentation. I'm going to review a few housekeeping items with everyone. If you notice that your viewer does not fit your screen, you can expand it by clicking the expand button located on the top right corner indicated by the red arrow. Now you'll see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar on the right of your screen by clicking the small red arrow located on the left of the toolbar. And then click the arrow again to expand the toolbar and it will expand. As I mentioned, for today's webinar, all participants will be muted. As we move through the presentation, if you have any questions for our presenter, we ask that you use the chat box on the toolbar. Simply type your question and hit send. And at the end of the presentation, we'll leave a few minutes for questions and answers. If for some reason we don't have enough time to answer all of your questions, what we're going to do is that we'll post them on our webpage with the answers provided by Dr. Hernandez. A recording of today's webinar along with the PowerPoint slides will be available at our website at www.attcnetwork.org/Hispanic and Latino approximately 1 week from today. You can also find recording and PowerPoint slides from all of our past webinars at the same URL. One NADAC, one NBCC, and one ICNRC continued education credit is available to those who attend today's live event. If you're interested in obtaining CEUs from these organizations, please email us at hispaniclatino@uccaribe.edu. As I mentioned, today's webinar is sponsored by the National Hispanic and Latino ATTC. As of October 1st of 2012, the network has been restructured and now consists of 10 regional ATTCs, 4 national focus area ATTCs, along with the network coordinating office. So as you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions. And you can see that we have the 4 national focus area ATTCs on the left of the screen. Today's webinar is the 30th in a series that the National Hispanic and Latino has been offering. The network is funded by the Substance Abuse and Mental Health Services Administration and serves a critical role in improving the health of the U.S. The network achieves this by translating, disseminating, and promoting the adoption and implementation of evidence-based clinical practices and strives to improve the health and wellness of individuals whose lives have been impacted by substance use disorders. So for any of you who want to learn more about the network's products, you can visit attcnetwork.org. As I mentioned, the ATTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental illness on America's communities through its programs and services, and demonstrates that behavioral health is essential to health, prevention works, treatment is effective, and people recover from mental and substance use disorders. So for those of you who want to learn more about SAMHSA, you can visit their webpage at www.samhsa.gov. Now I'm going to introduce our presenter, Dr. Hanner Hernandez. Dr. Hernandez is originally from Puerto Rico. He's bilingual and has worked for over 29 years in the health and human service field, developing, implementing, and evaluating culturally and linguistically competent youth and adult health prevention, intervention, treatment, and recovery support programs. He has many years in delivering addiction counseling and clinical supervision to professionals in the field. He's a professional trainer and facilitator and provides individualized technical assistance and support to organizations that provide addiction prevention, intervention, treatment, and recovery supports. Janet is a person in long-term recovery from addiction and is committed to eliminating health disparities by working at the national, state, and local levels. Currently, he is a senior consultant to the Massachusetts Department of Public Health Bureau of Substance Abuse Services, with a focus on access to recovery supports, and the 10 recovery support centers located throughout the Commonwealth. He also consults and teaches a number of courses at the New England Addiction Technology Transfer Center at Brown University, and is a colleague of ours at the National Hispanic and Latino ATTC. He was appointed to SAMHSA, bringing recovery supports to scale Technical Assistance Center Strategy Steering Committee in 2014. Hanner earned a Bachelor of Science in Human Services from Springfield College and a Master of Education with concentration in Counseling Psychology and Addiction Studies from Cambridge College in Massachusetts. His doctoral degree was earned at the School of Public Health and Health Sciences at the University of Massachusetts in Amherst. His major was Community Health Education and his minor was Social Justice Education. In addition, Mr. Hernandez holds an advanced certification in drug and alcohol counseling at the reciprocal level, is licensed in Massachusetts, and is a certified prevention specialist. So, before we begin our presentation, we're going to do our polls. So we're going to do a poll questioning, and our first question is, do you currently serve Hispanic and Latino populations with substance use disorders? Yes or no? So 93% of our participants say yes and 7% say no. Are you planning to serve Hispanic and Latino populations with substance use disorders in the next 6 months? Yes or no? So we have 82% say yes, 4% say no, and 15% don't know. What is your current professional role? And we have 26% social worker case manager, 43% counselors, therapists, 2% faculty research student, 12% government official policymaker, and 21% other. What type of setting do you currently work in? And we have 5% academic, 50% treatment, 29% government, 21% other. So now we're going to do our pre-test, and the first question is, opioid overdose rates are higher among Latinos and Hispanics compared to other ethnic groups. True or false? And we have 48% say true, 53% say false. Overdose rates and availability of opioid prescriptions follow the same trajectory. True or false? And we have 55% say true and 43% say false. Hispanics and Latinos have been living and calling attention to this crisis for decades. True or false? And we have 76% say true and 26% say false. So that's it for questions. So now I'm gonna have our presenter do the presentation. So I'm gonna give the control to him. Okay.
Thank you, Daris.
You're welcome.
And let me now transition to my slide. So bear with me for a second here. Are you seeing my slides, Daris?
Yes, I see them.
You are? Okay. Well, thank you, Daris, for that wonderful introduction, and thank you to all of the attendees on the webinar. I'm really happy to be here, and as Daris says, my name is Janet Hernandez, and you see my email and my telephone number. If anyone wants to reach me directly with any additional questions or comments, please feel free to do that. As Daris said, I am a person in long-term recovery, and what that means for me is that I haven't used a drug, including alcohol, for the last 30 years. My anniversary was on December 20th of 2016. What that has enabled me to do is to be a productive member of my family, first and foremost of my community, and to be free from many of the shackles that come with a substance use disorder. So I'm extremely happy to be here, and I want to thank you again for your attendance. I just want to remind you that if at any point in time you have a question, please type it into the chat, and towards the end we'll have some opportunity to discuss answers to those questions. It's important for us to understand the context in which we live in the United States, and Latinos and Hispanics, as you can see from the graph, currently make up about 17% of the total population in the U.S. We're the largest so-called minority group in the United States, and this graph is important because, as you can see, the Census Bureau has come up with projections moving forward in terms of what the populations will look like for Hispanics and Latinos. And if you look at 2050, 28%, 2060, 31%. And that should give all of us some level of urgency in terms of developing services that reach all folks, including Latinos and Hispanics. My next slide, or our next slide, is talking about Hispanic or Latino by origin in 2011 through 2013. These data are pretty much true today as well. But as you can see, the largest subgroup are Mexicans with 64.3%, and that is followed by Puerto Ricans at 9.5%. The Census Bureau does something that's really interesting. In addition to seeing the percentages for Cubans, Salvadorans, Dominicans, Guatemalans, and Colombians, then they lump all together certain groups from Central and South America and folks of Hispanic descent at 11.4%. The purpose of having this slide up is for us to understand that when folks say either Hispanic or Latino, and you see that we are talking about Hispanic or Latino because people decide to identify themselves in very specific ways, and we want to be as inclusive as possible. But many times what folks who haven't been trained to understand what the issues are, what they do is that they lump Latinos or Hispanics all together and think that one size fits all, or that they're all the same, or that we are all the same. And while we have many similarities, and that is true, there are differences that folks should attend to. The other piece in relationship to this slide here is that we should all be doing research at the community level to see who is actually in our neighborhoods and cities in which we provide services. And you can begin with a quick search on the net through the Census Bureau, but it also pays a great deal to actually go out into the community and speak to folks and see who's actually there. Some other data that is really important related to opioid disparities and disproportionate impacts are as follows. 25.6% poverty rate in 2012 for Latinos and Hispanics versus 9.7 for the total U.S. population. This is a major disparity that we have to take into account when developing, delivering services, and understanding what's happening at the community level. The rate of uninsured Hispanics is at 24.5%, almost 25%, and you should know that Hispanics and Latinos are the highest, have the highest percentage of uninsured people in the United States. And when you look at the folks who are born in the U.S. Versus the folks who have been born outside of the U.S., the Latino or Hispanic folks who have been born out of the U.S. have the highest percentage of uninsured people in the United States. Another major piece for us to wrap our heads around and to begin to understand has to do with mass incarceration and the overrepresentation of many minority groups. And here we're going to focus on Hispanics and Latinos in terms of being overrepresented within the criminal justice system, and understand that here we're talking about people who are incarcerated at the federal level, at the state level, at the county level, and the majority of people who are incarcerated in the U.S. are at the state and county level, so it's important to understand that, different from the federal level. But also, there are a number of people who are on parole, probation, engaged with criminal justice in many different ways, and there's an overrepresentation there as well. This didn't come about because somehow, some way, African Americans and Latinos are more violent or criminally oriented than other folks. You know, there is nothing in the literature that talks about that. What is in the literature that we can understand a great deal is that in 1970, we had 200,000 people incarcerated in the U.S. Fast forward to 2017, we have 2.3 million people incarcerated in the U.S., and that didn't happen again by coincidence or just because some groups are more have more criminal activity than others. There have been deliberate policies that have been set into place. So I'm going to review those, a couple of those very quickly, so that we continue to set the stage for the conversation going forward. If you can recall, you know, the United States declared a war on drugs around 1970. In addition to that, part of the 80s and 90s, the U.S. developed national as well as local policies regarding crack cocaine versus powder cocaine, mandatory minimums, school zones, and most of the inner cities in the U.S. are school zones. And so some of these policies don't affect necessarily the suburbs, but impact where large numbers of people of color, including Latinos, live. In addition to those policies, we develop criminal offender records, which follow people for the rest of their lives. And as you know, in some states, people coming out of prisons or jails are not able to vote. Those criminal records follow them for ever, and they impact housing, employment, services. It just makes it really difficult for people to come back into communities and be productive. And, you know, these policies, along with 3 strikes and you're out, and, you know, talking about people in inhumane ways, have contributed to these overrepresentations. We have a long waiting list for assessments and admissions into treatment. I just want to stop there and say, here in Massachusetts, where I live and work primarily, we have an abundance of services as compared to other parts of the country. I'm sure that you're familiar with this. And here, for an assessment, for a mental health assessment, for example, if you are Latino and monolingual and only speak Spanish, you're looking at anywhere from 9 months to a year out before you can be assessed. And depending on what part of the country people are at, these waiting periods become even longer. But we also have long waiting periods for admissions into treatment, even in treatment-rich areas such as the Northeast of the United States. Most programs have not been designed to meet the needs of the Latino or Hispanic population. As a matter of fact, most of our treatment system was originally designed to treat and provide services to white heterosexual males. And so if you are not from within that very specific category, then you run into issues of programs that are not designed to meet your needs. And just to add fuel to everything else that's going on, there's an underrepresentation of Latinos and Hispanics in the behavioral health workforce, and these all contribute to disproportionate impacts. In terms of opioid admissions and what SAMHSA published in 2015, and here we're focusing in more on Latinos, 17% of all Mexican admissions were for opioids. That is a significant number. Take a look at the 49% for Puerto Ricans, 20% for Cubans, and 22% for other Hispanics. And so when talking about opioids and what's happening currently across the U.S. regarding the opioid crisis, it's important to understand that different groups are affected in different ways, and the Latino is not exempt from that. And this slide also pushes me to better understand who the people are who are walking through the door, what are the presenting issues and diagnoses, and what are the best ways to treat them. Speaking of the opioid use in the United States, we just want to share some data which are extremely important for us to understand. Beginning with heroin and availability of heroin, you can see from the first bullet point here that from 2000 to 2008, approximately 500 kilograms were seized at U.S. borders. And then you see that over 2,100 were seized in 2013. So there's an increase in the import of heroin into the United States. This becomes really important. Costs are also important. A bag of heroin is very cheap, anywhere from $3 to $10. Here in the Northeast, in most of the cities and towns where I work in Massachusetts, it's about $3, nowhere near $10, very cheap. As a matter of fact, on the street when I speak with folks, they say 60 cans will get me a bag. And the first time I heard that, it was 60 cans of what? They say 60 empty cans that you can turn in for 10 cents a can. So, it's very cheap as compared to a major part of the 80s and 90s when a bag of heroin would cost anywhere from $30 to $50 in the cities where I live and work. So, costs have played a major impact, as well as purity. We're at an all-time high. And how do we know this? Confiscated heroin is tested all of the time to see purity level and what else is included in the heroin that has been confiscated off the street. This is important for us to understand because at the community level, when you speak with folks who are currently using substances, particularly those folks who have experience with substances from the 80s and part of the 90s and the early 2000s, many will say that the heroin now is no good, that it used to be more potent back in the 80s and 90s. And this is just not true. Based on the research that we have, it's not true. But that mentality, it pushes people to use more or not to take into account their level of tolerance. Another piece that is in the news as of late, and well, it should be, is fentanyl. And it was originally developed for treating pain, 50 to 100 times more powerful than heroin. We know that it's being produced illegally here in the U.S. and outside of the U.S., and that it's making its way into the U.S. Through the borders as well as through the mail coming into the U.S. in large quantities. And we also know that it's being mixed with heroin and or cocaine, depending on the region of the country that you're in. But across the country, we're hearing more and more and more about the use of fentanyl and the impacts of fentanyl. And these data come from the Center for Disease Control and Prevention. In terms of prescription opioids, another major driver in relationship to the crisis that we currently have, it's important to understand by way of context that the industry, pharmaceutical industry, argued that they were not addictive and actually put out statements that they were not addictive very early on when some of these powerful opioids were first came out. And we're talking about the mid-90s, around 1995, 1996. You can go back to the literature and you'll see that that is true. By 1999, sales had nearly quadrupled in terms of prescription opioids in the United States. And that is not because, well, let me talk about the next bullet point, which is we have overprescribed for pain management. Yet the U.S. doesn't suffer most of the pain in the world, and but still we have disproportionate number of people who have been prescribed opioids, and we're now learning that those mistakes are very costly. Now, the folks doing the prescribing, it's not because those folks were trying to do harm to folks in the community. It is a lack of understanding of substance use disorders, addiction, the impacts of overprescribing, and other factors as well. This, in turn, has created easy access for family and friends. If you can think of the millions of people across the U.S. who have access to prescription medications or opioids in their medicine cabinets, in their homes, in their refrigerators and cabinets and that sort of thing. And then, family and friends having access to that. And we know this because many of the people that we have interviewed, and there are studies about this, and data to prove this, they say that they first started with a prescription, and then others say they first started because they borrowed or took some pills from family members and friends. We also know that at the community level, prescription opioids are way more expensive than heroin. Here, again, in my community, it's about $1 a milligram. So, Percocet pill that's 10 milligrams will cost anywhere from $10 to $20, and a bag of heroin is $3. So it's not difficult to do the math that many people have transitioned to cheap heroin and then use heroin in combination with a prescription opioid. And this is a powder keg that has been exploding all over the U.S. In terms of opioid overdose deaths, just want to provide some data here so that we are familiar in terms of what's happening. Since 1999, the number of opioid overdose deaths has quadrupled. Now, I'm just going to flip back to the previous slide. Since 1999, sales have nearly quadrupled. In other words, these two issues, the overprescription as well as overdose deaths, have the same trajectory in the U.S. And I recently have gone to several conferences where there have been slides put up that demonstrate this and research that has been done to prove that. Overdose deaths and availability of opioid prescriptions, again, follow the same trajectory. Approximately 91 people die every day. So today, about 91 people will die as a result of an opioid overdose. And that equals about 33,000 people per year. And for the first time in 2015, those opioid overdose deaths surpassed deaths from car crashes and gun homicides. This should be very alarming to all of us. And prescription opioids continue to fuel this epidemic. And there is no one that I have heard who said that this is not true. And it's very much been documented by way of what the data says, not only by the Center for Disease Control and SAMHSA, but, state health departments as well as local health departments as well. So what do we do? There's obviously a crisis is declared, and I am, for one, really thankful that we, didn't double down on declaring a war, because one of the things that has come up very recently is that the so-called war on drugs has failed, and that the policies that were attached to that were primarily punitive and criminal justice oriented, and that we need to think about some things differently. At any rate, substance use disorder providers and advocates from the front lines, sounded the alarm and have been sounding the alarm for years in terms of, we've been building up to this, and folks who've been working in the field know this. Now, public health departments and providers respond and provide perspective, and the response has been, in a number of areas, including prevention, intervention, treatment, and recovery supports, but also providing data of the magnitude of the problem, as well as putting resources to work to address the problem. And most health departments will say the same thing. They don't have enough resources to respond to the needs that are out in the community. We witness at the same time a rise of vocal advocates representing individuals and families from middle-class neighborhoods. And we witness that because of the impact in those neighborhoods. Politicians become engaged, and many develop talking points, policy positions, and promise actions. I remember the presidential election and the many speeches that were given that included politicians talking about what they would do in response to this crisis. Many media outlets take notice, and so the national ones as well as the local ones. There are some really good folks in media who understand the need to do some responsible reporting and actually go out and investigate and get the perspective of families, friends, community, public health experts, that sort of thing. But there are still some stories out there that are inaccurate and sensationalize issues as well, instead of humanizing what's happening. But the media takes notice, and that's a good thing, and we need to do more to continue to encourage that. Criminal justice systems and first responders begin to take action. One of the first of its kind in the country was here in Massachusetts. It's called the Angels Program in Gloucester, Massachusetts, where the chief of police took a stand very early on and said, you know what, we're not arresting people who come to the police station, even if they have heroin or opioids on them and they want treatment. We'll check to see if they have any warrants, but what we're going to do is we're going to work with the treatment community, and we are going to do some referrals. There are excellent examples of those types of programs being replicated across the country, and first responders beginning to take action, including police departments, firefighters, EMTs, just everyone or most folks coming together and saying, this is an issue, it's an issue in our communities, and we need to do something about it. And a number of public policies are developed and resources are mobilized. I'll talk a little bit more about some of those public policies in future slides, but just setting the stage in terms of, a crisis is declared, that sort of thing. Coming back to some of the key demographics that are highlighted in the data in relationship to this crisis is that overdose rates are highest amongst people between the ages of 23, 24, and 54 years of age, with the majority of those being very young people, and so young folks are overrepresented in that data. And we understand that most deaths are occurring amongst Caucasians, Native Americans, and Alaskan Natives. This in no way should mean that other communities have not been impacted. And we also know that men are more likely to die than women, even though many women have died as well, and that those demographics are changing as we speak. Again, these are data from the Center for Disease Control and Prevention in terms of the key demographics that are highlighted. And to refocus the conversation back to Latinos and Hispanics, there are a number of perspectives and questions that have been raised from many communities. I'll take these from the perspective of the Latino and Hispanic communities across the U.S. And part of what they have been saying in town hall meetings, in conferences and trainings across the country is that we have been living this crisis and calling attention to it for decades. And the response primarily has been criminal justice response with policies that are punitive and locking people up, and dehumanizing folks with a substance use disorder, and justifying actions that again are punitive. It's declared a crisis, many people have said, when the white middle class are dying in the suburbs, and the approaches are somewhat different by way of what we should do. And many folks continue to be concerned about that because this will have implications moving forward. They ask, how well do we understand the needs and the impact that these issues are having amongst Hispanics and Latinos in the United States? They also ask what efforts are in place or being developed to reach Latinos and Hispanics, because we know that disparities exist, and they've existed for decades and decades, and we need efforts that engage people. And one of the questions that we've been asking recently and out loud in many settings is, how will the resources be distributed? If there's a slant in the media and there's a slant in some of the public policy makers towards a misunderstanding of and a misrepresentation of what the data show, then how will these resources be distributed? Are we going to be thinking about issues of disparities? Are we also going to be thinking about developing equity and addressing these issues in all communities, or are we going to continue to be concerned with one demographic of folks over others? And so these are key questions for us to ask and to think about. So transitioning from that, we just want to talk about some of the actions, approaches, strategies, and techniques that can work, have been working with people from Hispanic and Latino communities. And so that is the transition that we want to do now, and talk about opioid overdoses and some of the things that we can do. Some of the policies that have been developed are Good Samaritan laws and prescription monitoring programs. And here across New England, we have Good Samaritan laws, where if someone now calls the police station because they're witnessing an overdose and they were either using with the person, they're not going to be arrested, where in the past they were. And prescription monitoring programs are being widely used in our area and other parts of the country, and then some parts of the country are still trying to develop those. One promising thing that's happened, well, several, but another promising thing that's happening with the PMP programs is that Now we're thinking about how we share data over state lines, because we know that people have been doctor shopping and looking for ways to get prescriptions and to bring them across state lines. An important caveat regarding Good Samaritan laws: when you're working with communities of color, particularly Latino folks, there has to be a lot of education around Good Samaritan, because a lot of folks will experience something and they fear the police for many different reasons, and they might not call, even though there's a law on the books that says that they would not be arrested. But there are other things to take into account there. We should establish relationships with local public health professionals. We should understand who is at risk and why, and this requires doing some more research into speaking with folks and looking at what the data says, but at the community level, we should understand this a great deal. We should train all the staff on Narcan use, and if you work at an institution right now and you're on this webinar that hasn't provided training on the use of Narcan to reverse overdoses, and it's the most effective medication that we have, you should consider that. But above and beyond just training staff, we recommend that you develop a policy, because a policy within the organization has stronger legs for ensuring that there will be additional training moving forward and that there's sensitivity to what the issue is. We should educate clients and family members, and we're talking here about folks who are in recovery and folks seeking recovery, as well as folks who are actively using, because no one can administer Narcan on themselves. It has to be someone else. And when people use alone, they're at greater risk. When people are coming out of prisons and jails, they are at greater risk, among other high-risk areas. We should develop plans to monitor and support clients. I can't tell you the importance, to make the point of the importance of, if you have public restrooms in your places of treatment, service, outpatient, inpatient, what have you, be monitoring restrooms. We've had many people dying while in treatment. And so it's important that we have plans to support and monitor without being punitive or without going out and attempting to police people. That's not what we're talking about, but to monitor, be supportive, that sort of thing. When someone dies, it's very traumatic. When some of the people who died here in treatment, for example, a young man died in a treatment program here in Massachusetts on Friday, that impacted the entire treatment facility and the staff. And so monitor those places, support clients, that sort of thing. Provide ongoing support and supervision related to death and bereavement. Be trauma informed. The folks who are first responders, the folks who are treating people, the folks who have experienced an overdose death, who have responded to one, who have family members of, or who have clients who have all of a sudden died, they are experiencing death and loss and going through bereavement processes, and it's important that we take those into account. We need to understand that in terms of organizational governance and workforce actions, we need to understand that one doesn't have to be Latino or Hispanic to provide effective services. But one needs to be competent and know the population that we're working with and develop some skills and have some tools and resources to be able to do it. But you don't have to be Latino or Hispanic. Now, that said, language does matter. And so we know that Latinos and Hispanics speak a number of languages. And for the most part, people start talking about Spanish. Spanish is one of those languages. But we have many Latinos who don't speak Spanish. They speak English, or they speak Portuguese, or a form of Portuguese if they are, for example, from Brazil. So think about language in both service delivery as well as engaging people from the community in many different ways. And let's not assume that one language is preferred over the other until we have some data that backs that up. We need to continue to recruit Latinos and Hispanics to our boards of directors. Look inward into your organizations. If you're on this webinar and going back to your organization, ask who's on the board, who's represented there. Many of you said that you're currently servicing Latinos. Are Latinos represented on the board of directors? If you're interested in servicing Latinos into the future and you don't have folks on your board, it might be worthwhile, it is worthwhile to recruit some folks to your boards. Review and revise organizational policies and procedures. If you're learning more about the needs of communities, particularly Latinos and Hispanics, then you would need to revise some policies so that people feel more welcome, so that they're treated more effectively and efficiently, and that your organization improves outcomes and engagement at the community level. And we need to hire and retain Latino and Hispanic staff at all levels of the organization. And I can tell you how many organizations I walk into and they say, you know, we provide services to Latinos. And when I ask who is there to be able to do that in multiple languages and on the staff, they say, no, we have a receptionist that speaks Spanish. That is not enough. That is a step in the right direction. But we need clinicians, we need counselors, we need supervisors, middle management folks. We need people who understand what's happening at the community level, and all of these things move us forward into what we need. We need to incorporate class standards from the Office of Minority Health. And if you haven't heard of class standards, please visit the Office of Minority Health website or Google class standards, and that's culturally and linguistically appropriate services. We have a blueprint for helping organizations, programs, systems, as well as individuals as to what to do to become a little bit more culturally and linguistically competent, and to provide those services in a way that are meaningful. We need to provide ongoing training to existing staff around these issues. We need to provide culturally intelligent supervision. What we mean by that is that all of the learning around culture, cultural competency, linguistic competency, and all of the issues that I have been presenting here are incorporated into supervision with the folks who are doing the work with clients on the front lines. We need to learn about and incorporate best practices. There are many who haven't made their way into evidence-based models, but they are practices that work, and we need to learn about those. And we need to adopt and tailor evidence-based models for working with Latinos and Hispanics across the country. In terms of understanding and attending to cultural elements, I just want to briefly review that we have research, we have training curriculum, we have information about cultural elements that are very common amongst Latino and Hispanic groups across the United States. You see some of these here, the emphasis on family or familia when approaching treatment and understanding of that. The need to understand the role of respect or respeto in engaging populations and communities, and that this might take a little bit more time in working with Latinos and Hispanics, especially given the current climate in the U.S., but that respect is at the center of what we should be doing. This whole idea of personal relationships or personalismo, you know, Latinos and Hispanics will expect to share personal stories, but they also expect us as providers to have some reciprocity in that. In other words, to share and to become a little bit more personal. And that little bit of work goes a long way. That might be problematic for some folks who have been trained not to share any personal information, but we need to think outside of that box. The use of trust or confianza becomes extremely important, as well as spirituality or espiritualidad, which might be similar or different for some people regarding religion or religion, but these cultural elements can help us understand and engage people in a more effective way. The Latino and Hispanic ATTC has developed a number of products that train people in these cultural elements and engagement with the Latino community. And again, this is not to say that all Latinos practice this stuff in the same way, but there are starting points regarding commonalities across groups in the United States. We need to engage at the community level. And by here, what we mean is that if those of you in organizations that are currently supporting, that are currently providing services to Latinos or are interested in developing those services, we need to get out of our organizations and engage with the community. One of the things to strive to understand are immigration issues. You know the climate on immigration right now in the United States, and you know how fearful people are at the community level. And if you don't know, attempt to understand those issues, engage with organizations, groups, individuals who are providing immigration-related services so that you become more aware of what they are. Have a presence in the community. Go out. It's not just about people coming to us and into our agency and into our office, and that's how we're going to engage with people. If trust and personalismo and respect are, common cultural themes here, then having a presence in the community demonstrates respect, trust, confianza, and those sorts of issues. Have folks conduct outreach on a regular basis, be out, present, visible, mobile in the community. We should support cultural and recreational activities. That, as organizations, as individuals, that demonstrates caring and understanding that we want to develop long-term relationships and not just a relationship where you come in and you're assigned to a counselor and the counselor sees you and that's it. Develop relationships with community-based organizations and faith-based organizations. These organizations at the community level who have been developed to reach and engage Latinos have already developed trust. And so if you develop memorandums of agreement, of understanding, that will increase your chances of engaging with folks. Develop and foster a culture of learning within your organization about the Latino and Hispanic community, about the issues that we've been talking about, because when that culture exists within the organization and people come into the organization, they will feel like they're being respected, that they're being engaged, and that they value and that people care about them. So that's engagement at the community level. In terms of recovery and recovery supports, understand and support the multiple pathways of recovery. Those of us who do treatment as well as recovery supports need to understand that not everyone is going to get better using the same type of modality or the recovery pathway. There are multiple recovery pathways. Our role is to understand what those are and to support people in making their own choices in selecting a pathway and then us supporting them in those processes. In other words, my way or the highway has not worked and doesn't work and should not be the way that we engage folks. The way that we engage folks is by supporting options and giving back power to people to make their own decisions. We need to attend to the multiple needs. You talked about criminal offender records earlier, but there are other issues by way of barriers for folks, including Hispanics and Latinos. And these barriers are not unique to Latinos or Hispanics, but they are at the heart of many of the issues that people face, including transportation, housing, employment, income, issues of language, all of those things that I've mentioned earlier. Consider incorporating recovery coaching. We know that the use of peers works, and we know that there's a movement across the country for training thousands and thousands of peers to do this work. If you haven't heard of that work, please do some research. On the SAMHSA website, there's information about different models that we have been using across the country. We have recovery coaches in the ERs. Currently here in our state and in our region, we have them in treatment facilities, in recovery centers, in police stations, in drug courts. We have them all over the place, and they do work and get great results. We need to create opportunities to give back. Most people in recovery talk about giving back. And this is connected to purpose and purpose in life. And so creating opportunities for Latino and Hispanic folks to get back, to become engaged, is a major way of engaging people in this process. That is our last slide for today. And what we want to do is allow a few minutes that we have for some questions. I'm going to turn back the presentation
you can leave it like
to...
that. I can ask the questions.
Okay.
Okay.
Okay. So go ahead, Daddy.
So, Hane, we have a few questions. The first one, does the statistic for current incarcerated Hispanic Latino include those in immigration detention?
No, they don't. So when you add those numbers, they are much higher, a lot higher.
Okay. We have a question regarding the waiting periods. What do you think is the problem for long waiting periods for Latinos?
So for some of the evaluations that I was talking about by way of mental health assessments and that sort of thing, some of the reasons are that we don't have the personnel, the psychiatrists, psychologists who are bilingual, who can speak with folks and do these assessments, and most of the folks have long, lists of people that are waiting. So when you get into issues of monolingual Spanish, monolingual Portuguese, monolingual other languages, it becomes, that becomes the barrier, having enough people who can do that. And please, this is related to language, do not use kids who come into your places of service to do translation. Do not use someone who hasn't been trained as a translator, a family member, someone from reception, or someone who works in janitorial services. That doesn't work. We need qualified professional folks, which speaks to the need of getting more folks into the field who are bilingual, bicultural, to be able to do assessments, that sort of thing. On the other side of these waiting lists are programs. And so if you have programs that don't have folks who can speak the language, then they can't accept people. So they have, the programs that can accept people who speak different languages, then they end up with a very long waiting list. And that's a part of the rationale in terms of what's happening. And then the lack of programs that are designed to meet the needs of these populations are few and far between. And all of those things combined, I'm sure that there are other reasons, we end up with long waiting lists for people. And what we have done traditionally in our field is that when someone doesn't do well in programs that weren't designed for them, we blame the person. They somehow were deficient, resisted treatment, or didn't want treatment. We rarely ask the question, was the program designed to meet their needs? And so it's a combination of things.
Okay. Do you know of any programs that are helping people who are interested in becoming Latino counselors?
Yes, there are a number of workforce development programs. As a matter of fact, if people want to have a discussion with me offline in relationship to that, I'm more than welcome to do that. I have run a program here in Massachusetts for over 20 years that helps Latino folks who want to become certified or licensed drug and alcohol counselors. This includes folks who are currently working in the field as well as people who want to enter the field. And we have two training sites, one in Boston and one in the western part of Massachusetts, and we have long waiting lists. There are similar programs that have been developed in other parts of the country, including California, in Texas, in Chicago. And again, if people are interested in a conversation about those, they're going to email me or call me, and we can have more conversations about what those are. And this is in response to the fact that we have a workforce crisis in this country around behavioral health. And it's a well-documented workforce crisis by SAMHSA and others. And we know that the majority of the people who work in the field are baby boomers and are retiring very soon. They're also white, and the majority of the people walking through the door requesting services these days are younger and more diverse. And so we should create more pathways into the field and attracting people better. Also, there are a number of universities and colleges across the country who are creating pathways and into this field and are creating programs within schools of social work, human services, to train people in behavioral health. So there's a number of opportunities across the country.
Thank you. I have another one. You talk about efforts from the law enforcement, first responder, social services perspective. Are there any programs in the medical community that you know of to address the overprescription issues?
Yes, and so there are a number of states and territories that have passed laws to train, for example, here in Massachusetts, to train all medical providers in substance use disorders. Before this, you could have gone through all of medical school without learning anything about substance use disorders or addiction. And so there are laws on the books right now to train everyone who's prescribing and who's a doctor, but also training people within the medical schools, those folks who are coming into the medical world, so that they better understand substance use disorders, that sort of thing. So that's at the sort of training part of the professionals. As well as in nursing schools, there's more and more education being added to those programs so that people understand these issues a lot better. Within hospitals, universities that are connected to hospitals, but within hospitals and the federally qualified health centers, there is enormous work, a lot of work that's being done around this very issue by way of integration of behavioral health services into those systems and training people up from within health services to understand better these issues, as well as partnering with community-based organizations and what's the best way of doing that and engaging with community in relationship to that. I'm currently supervising a group of medical doctors now who are providing medication-assisted treatment. And, those are promising things that are not just happening here in Massachusetts, but across the country. And I applaud you for the question, and I encourage other folks to think about those things a little bit more closely. And as you go back and think about your organization, hospitals as well as these health clinics are partnering with community-based organizations to do that integration so that there's opportunities for us to be more proactive in that area.
Mm-hmm. So there was another question that I think you just answered. How can primary care physicians from FQHCs be supportive in recovery, treatment, and efforts?
Yeah, and so talked a little bit about that by way of the medication-assisted treatment programs, but also I think that, when a doctor speaks about these issues, the importance that's given to it is somewhat different from when a lay person talks about this. That shouldn't be that way, right? Someone in recovery has as much to say about this as a doctor, but encourage your local doctors from the federally qualified health centers and from your hospitals and institutions to speak out, and many of them are, and many of them are really good at talking about these issues. And training doctors, training entire health centers is where it's at by way of creating awareness, and then finding champions, like we have found champions within criminal justice worlds, finding champions within hospitals and those centers to be the champions for this issue. And then other people rally around them are some of the thoughts that I have around that.
Okay. So thank you, Hannah. We're going to leave it there. And I want to remind the audience that there are a few other questions that I'm going to be sending Dr. Hernandez possibly tomorrow so that we can have the questions and answers on a Word format available at our website. Also, a few of you have asked about the PowerPoint slides. You have a handout available if you're participating in this webinar. There's a handout that you can access with the slides, but also we'll have a recording on our YouTube channel as well as on our page. Okay?
I just want to thank everyone for your questions, your participation, and we look forward to future communications with you. So thank you very much. And thank you, Daris, for all your support and guidance throughout this process.
No, I want to thank you. Haneri is a longtime colleague and personal friend for me in the ATTC, in the National Hispanic and Latino ATTC, and I always enjoy listening to your presentations, so thank you. I want to remind the audience that a recording of today's webinar and as well as the PowerPoint slides will be posted and available at our webpage at www.attcnetwork.org/Hispanic Latino. So this concludes our webinar today, and I would like again to thank Dr. Hernandez, and please look at our websites to learn about future webinars. As you leave today's webinar, you'll be directed to complete a brief survey about your experience. Your feedback is very important to us, and we appreciate you taking the time to tell us what you thought of today's webinar. So, gracias.